Good afternoon, everyone. This is Molly Young from the Miami University Alumni Association. Today, we are proud to present the webinar, Surviving COVID-19, Making Informed Decisions During a Global Pandemic. Your instructor today is Dr. Philip Smith, Assistant Professor in the Department of Kinesiology and Health at Miami University. Many thanks to Dr. Smith for sharing his knowledge with us today. Questions were collected during registration, and Dr. Smith will address some of them throughout the webinar today. You will also have the option to ask questions during the webinar by clicking the Ask a Question button. Today's webinar will last about an hour. And with that, I'll turn it over to Dr. Smith.
Okay, thank you. Thank you, everybody, for tuning in today. I'm excited to get into this material and hopefully have a little bit of dialogue with you in terms of questions and answers. I'll tell you a little bit more about myself before we get started. So I'm a professor, assistant professor at Miami University. I teach in our public health program. Right now I teach courses in global and national health policy, in social marketing, and this coming semester I'll be teaching Introduction to Public Health, and then have an epidemiology course in the pipeline. So my background is in public health broadly, most specifically epidemiology, which is obviously very relevant right now, but not just epidemiology. So I have education and professional experience in the field of health policy, as well as health behaviors. So understanding why people do and don't make various health behavior decisions, and how people can be encouraged or supported to make healthy decisions. My education is, so I have a degree, a master's degree in epidemiology, a PhD in community health and health behavior, and then postdoctoral training in epidemiology and biostatistics. My grad school was at SUNY Buffalo, and then my fellowship was at Yale University. And I have about 12 years of combined education and experience. So how I'm talking to you today, I don't have any conflicts of interest in this material, so I don't have any direct ties financially to this type of information, other than my retirement, but that's a long way off, so hopefully I should be okay in that regard. I'm really speaking to you as somebody with, like I said, training experience, but I'm also a father, a family member. I'm a child. I have parents. I'm part of a community, and so the perspective I'm bringing today is a combination of my expertise and how I'm approaching information in this kind of crazy time in order to make decisions in my life that have ramifications in terms of my own safety and well-being, the safety and well-being of my family and my community, and students and colleagues. So that's the perspective I'm coming from today. One thing I can say for sure is that it's honest. It's my honest perspective. So for what it's worth. So with all of that said, how about I go ahead and start getting into my presentation. Okay, so here's the problem we're in. And I'm not going to spend too much time talking about the problem because we're all aware of the problem. So this is a very new situation, obviously. There is an immense amount of information and opinions, as well as access to that information and opinions through social media, news outlets, etc., friends that are sharing their opinions on social media. So it's just a bombardment of information, and we're not all epidemiologists and public health experts. So the type of information is somewhat new for a lot of us. So, and then like always, like every day, we have to make decisions, and those decisions can have some minor or major ramifications. So we're in this kind of situation where there's tons of information, but not everybody is really skilled, and I think that's completely understandable in interpreting this very specific kind of information. So it's a very challenging time to be in. So through this webinar, I'm hoping to give you a little bit more information on basic epidemiology as it relates to this pandemic. We'll talk a little bit about comparing COVID-19 to other infectious diseases that people have been talking about. What I hope is to give you some more tools that you can more confidently, proactively stay informed about what's going on and to more confidently interpret information about coronavirus and COVID-19 from various sources. And then, of course, the be-all, end-all goal is to take that information and make decisions that are right for you. So this is a visual of the scenario, and this demographic fits me, but I think a lot of people can relate to this situation right now. And it ties into that information overload that I mentioned, where we're spending, whether it's a computer or a phone or a TV or conversations, there's just a lot of time trying to keep up with what is going on. So like I said, my perspective that I'm bringing here is, how am I approaching information? As somebody who has relevant expertise in training in the public health domain, how am I approaching this information? And what I can say is that the way I'm approaching information seems to be pretty consistent with my public health and epidemiology colleagues. So I'm trying to boil things down pretty simply. I'm going to talk about three things that I'm not paying that much attention to. And after I do that, first thing we're going to do is take a little break, and I'll have some time to answer some of the questions that you submitted during registration. And then I'm going to talk about three things that I am really paying attention to, and then principles, general principles for consuming COVID-19 information, some takeaways, and then we should have some time, a little bit of time at the end to answer any live questions that you might have. So first things, these are the things that I'm paying attention to, but not that much attention to. The list right here: death percentages, herd immunity, and comparisons to influenza and other pandemics. And I'm going to talk about each of these points in themselves. The first one being death percentages. So these are some examples of what you might see in the news. One here saying new data suggests coronavirus isn't as deadly as we thought. Another one here saying antibody tests support what's been obvious: COVID-19 is much more lethal than the flu. So clearly contradictory information coming from different sources, and often based on political leanings. So in terms of the basic epidemiology that we're thinking about here, the term is the case fatality rate. So these are the percent of cases of any given illness that die from that specific illness. And the formula is really basic: deaths from COVID-19 divided by cases. So in plain language, if you get COVID-19, what's the chance you'll die from it? Case fatality. So here's the part of the reason I'm not paying too much information to this number. If you look at this formula, we need to know accurate information about deaths, and we need accurate information about cases. And you may see where I'm going with this. In terms of deaths, the way we've been calculating deaths is confirmed and probable. But for most sources, there's been concern about including probable cases. One thing I can say is that from an epidemiological perspective, that's always what we do. So for example, when we tally flu deaths in a given year, we include probable cases. It's just the way we typically calculate mortality rates when we look at populations. So I'm not super concerned about that. On the other hand, we likely have people who aren't being counted because they died in their homes and things like that. So you've seen both people saying there's too many, there's not enough. I'm somewhere in the middle. and so the information on deaths in terms of accuracy isn't super concerning to me. But cases, on the other hand, we really don't have good information on the number of people who've been infected. Confirmed cases obviously is limited based on our ability to test. We know that. And we've seen some studies coming out based on antibody tests. But these antibody tests, I'm going to go a little bit more into the tests in themselves in a bit. But We don't know how accurate they are, and we're getting widely varying rates based on the population tested. So in Spain, they had 5%. The study that came out of California was much higher than that. New York was somewhere in the middle. So those numbers aren't greatly accurate, and they aren't all over the place. So one reason I'm not paying that much attention to case fatality yet is because we don't have accurate information. Another reason, it's only part of the picture. So we're also really concerned about not just mortality, but what we call morbidity, severe cases, hospitalizations, long-term health consequences. And so focusing really on the death rates doesn't give you this full picture. Here's another reason that percentage isn't that meaningful in itself. So say we have two viruses. One has a 5% death rate, the other one has 0.1%. Okay, so much higher death rate for virus A. For virus A, we have 500 people who get infected over the course of, sorry, I have to just move a box here, over the course of a year. And then for virus B, 500,000 people get infected over the course of 1 month. You can probably see where this is going here. For virus A, that means 25 people die in a year. For virus B, we have 500 people dying in a month, right? Virus B is a very much more serious scenario. The reason this is an issue is that it doesn't, the percentage in itself doesn't take into account the number of people who are getting infected and the amount of time it takes for them to get infected. So that percentage in itself, again, provides really limited information. We already know enough in the sense that this infection has a potential to overwhelm healthcare systems, the potential to. We've seen concerning situations, for example, in Italy and New York City. So just to summarize, the percentages for death rates are not that accurate. They don't tell us about the full picture in terms of serious illness or long-term health consequences. They don't account for the number of people who are sick or the amount of time. And we've already seen some really concerning occurrences of healthcare systems getting to a point of starting to be overwhelmed. So that is a summary of why I'm personally I'm paying attention, but just not giving that much mind to arguments either way over this is really deadly or this isn't really deadly. The second thing on the list here is herd immunity, and there's an asterisk there. Yeah, you might have heard people talk about herd immunity. Here's a couple of contradictory examples. Herd immunity is a fatal strategy we should avoid at all costs. Or we need herd immunity, says Texas Congressman Chip Roy. You're seeing a lot of contradictory information about herd immunity. So what is herd immunity? Herd immunity, basic concept, there's enough people with immunity to an infection to protect people who are not immune. So if everybody is around me, who is around me is immune, I'm not, the likelihood of me being exposed to somebody who has the infection goes way down. So we have herd immunity for measles, we have herd immunity for polio, we have herd immunity generally for chickenpox at this point in time. There are some requirements for herd immunity to work. It can be a really important and effective public health tool, but there's requirements. So the general estimate is that 70 to 90% of people in a community, in one particular community, have to have been infected and developed long-lasting immunity. Or a vaccine's available that gets us to that number of 70, 90% in the community having long-lasting immunity. And the reason that there's a range for that percentage has to do with a number of factors, including some viruses, for example, are much more infectious than other ones. So measles, for example, is much more infectious than the flu or coronavirus. So you need more people to be immune in order to have that herd immunity. So that's why we have a range. So why is that number scary in terms of COVID-19? So say we go right in the middle and we say we need 80% of the US population to develop herd immunity. That's 80% of the US population, which is 262 million people. So even if we have really conservative estimates of the case fatality rates, we're still talking about millions of deaths in a short amount of time. So that's why this number is, and this doesn't include people getting seriously ill or developing long-term complications from infection. So this is the reason why a lot of public health people and epidemiologists are scared about the idea of just flat out taking a herd immunity approach. Not only that, but we don't understand about the immunity in relation to COVID-19 yet, and this particular coronavirus infection. Best case, based on evidence, it's a year or maybe a couple of years. Worst scenario, it's only a matter of weeks or months, and we don't know where we are yet. And I'm going to talk a little bit more detail about immunity specifically a little bit later. So the reason I'm keeping an eye on herd immunity is that it's a really important tool. Like, it could make a big difference if we can get to herd immunity. But the reason I'm not there yet is, most importantly, we don't understand immunity for COVID-19 yet, and that has a major impact on our ability to achieve herd immunity. And then second, even if the immunity for COVID-19 works out in a way that is advantageous for herd immunity, if we tried it at this point, it probably wouldn't go that well, and the numbers get pretty scary pretty quickly. So for me, that's why I'm not paying that much attention to it right now. The third thing on the list here, comparisons to influenza and past pandemics. So here again, we see some of these contradictory headlines. COVID-19 lethality is not much different than the flu, says new study. COVID-19 is no worse than the flu, hardly, contradicting each other. So at this point, I think it makes sense to talk a little bit about some basic epidemiology again, and differentiating an endemic from an epidemic from a pandemic. So endemic is the normal occurrence of disease. So we're thinking baseline, what's normal, what do we expect? The seasonal flu in the United States is endemic. It comes every year. There's variability in how serious it is. In some years, it gets out of control, so it does reach what we call epidemic. But from a year-to-year basis, it's there. We expect it. When we transition to calling something epidemic, it's when it's beyond normal within a community, territory, or country. So we're thinking excess. We're thinking new. An example from recent years is Zika virus. One thing that's interesting to point out is that we could have a new epidemic for something that's not as serious as something that's endemic, but we still have to take it seriously. So it's not a matter of it's not only a matter of how serious things are. It's really, the distinction is whether or not it's something that is there and we expect it versus something that we don't expect. And then the last one here is pandemic, which is simply epidemic in several countries. So we're thinking excess, we're thinking new, and we're thinking in multiple countries. So an example here is swine flu from 2009, 2010. So when we think about endemic versus epidemic, in the US, endemic demand is generally met by supply, right? That's how things work out to a degree. So we know the seasonal flu is coming. We can address it because we have the capacity to do it. Epidemics, even if they aren't as serious even if they're less serious than something that we already expect, can tax our system because we're not expecting it. So we don't necessarily have the supply to meet the demand. And then not only does a pandemic tax supply, but it can also be harder to get rid of, because if it's localized to a particular nation as an epidemic, if we control it in that country, then it's controlled. But if we controlled it in that country, but it's still going on in another country, and then people are traveling back and forth, it makes things hard to control. So that's why there are increasing levels of concern from endemic to epidemic to pandemic. So here's why I'm not paying that much attention. As with any epidemic or pandemic, we're concerned about excess, death, and disease. This is what can overwhelm resources. So even if COVID-19 was less serious than the flu, it's still something we would be talking about as an epidemic because it would still have the potential to overtax our healthcare system. So what COVID-19 adds on top of this seasonal flu is much more relevant than a side-by-side comparison. With that said, based on the best information possible, we know that for COVID-19, that excess as an epidemic is concerning. So for seasonal flu deaths from 2019 to 2020, this past season, which was a fairly serious year, we had about 60,000 deaths over 7 months. And that's a little bit more than we're used to, but we handled it because we have the capacity. With COVID-19, we saw about that same number of deaths over 7 weeks. And again, that's in excess to what we're already expecting. So that's why we ran into a situation in New York that got pretty concerning there for a little while. So in terms of the number of deaths, so SARS, if you think back to SARS, there weren't any deaths in the United States. If we're thinking about comparing to the H1N1 swine flu in 2019-2020, there were about 13,000 in the US over the course of a year. We have multiple seasons there. With COVID-19, this information is a little bit old, 75,000 deaths over 2 months and counting. And again, you may say, well, that includes probable deaths, but so does that estimate of 13,000 from H1N1 swine flu. That's just the way we calculate mortality rates. So it may be less, but it's still clearly different than other epidemics and pandemics that we've had in recent times. So again, the reason I'm not paying too much attention to these comparisons, the reason that I don't know that they're super meaningful from a public health perspective is that we know it's different in some ways, and we're concerned about the excess more so than the comparisons. So when I'm looking at information, and this is a recommendation, I'm aware of these conversations, but I'm not paying that much attention to them for the reasons that I just talked about. And that cuts out, at least from what I'm seeing, that cuts out a lot of information that we're coming across already. So I think that if you think about at least the way I'm thinking about these things, and when I am in an information overload situation with a fair level of capacity to handle this information because of my expertise, one thing that is useful to me is kind of just knowing what I can set aside a little bit and not pay that much attention to in terms of relevance for my own risk, for my community's risk, and from a public health perspective. Okay, so the next thing, that's the first part of the presentation. The next thing I'm going to do is answer some of the questions that you all submitted during registration. We'll get through as many as I can in the next 7 or so minutes, and we'll go from there. Okay, so I'm pulling up the questions. So the first one, and this is a general question that I've got a lot in the recent weeks especially, is this sort of fill in the blanks situation. If I am blank, to what extent should I blank? Or if I am going to blank, to what extent should I blank? Basically, if I am a younger person, to what extent should I wear masks? If I am an older person, to what extent should I social distance? If I am, or another variety of this is it okay getting really specific? For example, I've been asked, is it okay for me to hug my grandkids? Is it okay for my kid to go play with this other kid in this really specific scenario? And I get where these questions are coming from. Because people want to know how to sort of live their lives in a way that they don't feel terrible and in a way that provides needed human connection and things while still keeping safe or while staying within somebody's individual risk tolerance. That's a phrase that's coming up a lot now, is risk tolerance. And my general response to these questions is I'm not thinking about things in this way. I'm not thinking about this particular situation or this particular situation because the lack of understanding that we have at this point is still kind of scary for me. We know the things that you can do to protect yourself. Like, we know social distancing. We know that wearing masks help protect other people, especially. But when you start getting into different situations, like I'm outside versus inside, we know outside is better than inside. We don't know how much better it is. When we think about if two people are wearing masks compared to one person, we know that 2 masks is better than 1 mask. We don't know how much better. We don't know how much risk you're reduced by doing these things. We don't know the environmental context. So we know, for example, that in humid weather, there's less risk of transmission than in really dry weather, because in humid weather, particles tend to fall, whereas in dry weather, droplets tend to be more suspended in air. And airflow and all these kinds of things come into play where it's literally impossible to say in any one given situation, this is what you should do, or this is what you shouldn't do. So people ask me those questions and it catches me off guard a little bit. That's not the way that I'm thinking about it, because I'm just kind of generally thinking about where the overall level of risk is. And I'm just generally doing the things to be as cautious as I can. And I think that that's generally the approach of people in the public health field, is not thinking about this scenario versus this scenario versus this scenario, but just generally realizing there's so much uncertainty right now. So generally trying to be cautious within your own level of risk tolerance and within your own needs. And I don't want to discount anybody's needs in that sense. One thing about risk tolerance is we don't exist in a vacuum. So anything you're doing could affect other people at some point in time, right? So if you have low risk tolerance or high risk tolerance and you're going to go out to a club and be around other people and not wear a mask, are you going to visit your grandparent or something like that later on, or in some expected ways? Or are you in a relationship where somebody has low risk tolerance and another person has high risk tolerance? So the thing with risk tolerance is really just not thinking about yourself in a bubble, but then again, making decisions that are right for yourself. I took a little bit of time with that question because it's probably the most frequently type of question that comes up. And the answer is that there's no way of knowing risk for any particular scenario right now. And so the way I'm thinking about it and the way that other people that I know in the field are thinking about it is just generally being as cautious as you can. Another question was, what's the most reliable source of tracking data? And specifically, the Atlantic's COVID tracking project came up. I've been using Worldo, and the numbers kind of line up. CDC's numbers are a little bit lower. The thing about tracking data is that the media sources are working a little bit faster and less conservatively than official sources. So it's not necessarily what's the most reliable, it's just understanding how they're tracking data and whether they're being really conservative or not conservative or less conservative. And the answer is, somewhere in the middle in terms of the numbers that you're seeing, but also data tracking is limited by the accuracy of the data that you're tracking. So if you're tracking daily cases, for example, it's impacted by availability of testing and accuracy of testing and all these other things. So I'm keeping a loose eye on tracking data, but it's something that we're kind of keeping a loose eye on because there's so many other things to be paying attention to. Another question: what are the most unbiased sources of information? So in my opinion, the most unbiased sources are official sources of information. So at the federal, state, or county level, those sources of information tend to be really conservative and a little bit behind the times. So I am not only going to those sources because I'm interested in new information that's coming out. So media information is much less conservative. So you have like two extremes. You have really conservative information coming from official sources, really unconservative information. I don't mean politically unconservative. I just mean in terms of a willingness to provide interpretations and make conclusions from new information. And with media, in my opinion, no media is unbiased. And even if you have a general source that's relatively unbiased or in the middle, I guess, then you might have reporters that are biased. So I talk a lot with my students about health information in the media. And what we talk about isn't necessarily trying to find unbiased information. It's being aware of, getting really skilled at recognizing the bias in all of the information that we're seeing and then interpreting the information as such. That's my approach. I don't really look for unbiased information. I read information from across the board, but I'm generally aware of the biased tendencies from different sources of information. And that's something, you can Google bias of media sources and get some nice visual graphics of what's maybe more biased or less biased. So again, I'm reading a variety of sources of information. I'm reading official sources for conservative stuff. I'm reading media for less, more timely stuff, and from a variety across the board, and just keeping in mind the bias inherent in that type of information and not taking any one source of information as factual. What are the most effective? I'll do a couple more here pretty quickly. What are the most effective respirators, face masks is a general question, and how effective are face masks and respirators? I don't think I get into this otherwhere in my presentation. So I think one thing to point out is the difference between something that is personal protection versus source control. N95, N99, and 90 respirators are intended to be personal protection. So they are intended to filter more of the stuff that you're breathing in. Face masks, cotton face masks, surgical masks are intended to be source control. So they're intended to filter what's going out, right? So face masks are not a tool, are not supposed to be an effective tool for protecting yourself. That's the respirators. Now, there have been studies that have shown that there isn't much of a difference in terms of personal protection. However, those studies have some issues with them that I don't have time to get into right now. So I think the most important thing to recognize is that the N95 and N99 respirators are meant for personal protection. Face masks, surgical masks are meant for source control, for protecting other people. And in terms of cotton face masks, when you're thinking about what will work best, layered cotton or thick cotton is going to work better than thin cotton, but you have to trade that off with your ability to breathe. Tight fitting, but securely fitting around your face is a really big thing. So if you have air pockets coming in, that's gonna protect people around you less. And if there is any benefit to you, protect you less. So snug fitting and layered or thicker cotton. How dangerous is singing versus talking? So I think this one is, there's no clear answer to how dangerous it is. We don't have that information. What we know is that singing is probably more dangerous than talking, and talking is probably more dangerous than not saying anything. But if you're singing really quietly, that is probably less dangerous than talking really loudly. It all has to do with the force that you're projecting water droplets through your breath. So when you're singing, you're doing that at greater force. When you're talking, you're doing that at greater force. So these things will project the air droplets that contain the virus to a greater degree. And the more consistently you're talking without taking breaks, it's the same kind of thing. So it's the rate and distance that this stuff causes things to flow, but we can't really say how dangerous is it specifically. Other questions had to do with testing, which I'm going to talk about in the presentation. So what I'm going to do now is get back into the presentation. And then, like I said, we will have time for some live questions at the end. Give me 1 second to get back where we were. Okay. So these are 3 things that I am paying attention to. These are 3 things that I think are potential game changers in terms of the scenario that we're dealing with. Immunity, availability and accuracy of tests and vaccine and treatments. So the first one I'm going to talk about is immunity. And again, you're seeing these kinds of the headlines here. Does COVID-19 infection equal immunity? Can antibody tests tell if you're immune to COVID-19? One thing that's interesting is that when you're asking questions about immunity, there's less divergence across politically biased sources of information. So that's something that's interesting to think about. So what we're talking about here is something called acquired immunity, and it's the body's immune system and how it learns to fight off specific infections with what we call antibodies. And this can happen from prior infection, mostly happen from prior infection and from vaccination, especially for older children and adults. So when it comes to acquired immunity, some viral infections result in immunity that lasts for several or many years. Measles is an example of that. Some viral infections result in immunity that lasts for a more intermittent amount of time. So maybe a year, maybe 2 years, maybe 3 years. And that's what we saw for the coronaviruses that caused SARS and MERS. Some viral infections result in immunity that lasts only for a matter of weeks or months. And this is what we see for the coronaviruses that typically cause the common cold. So there's variability from virus to virus in terms of acquired immunity. The likelihood of immunity is going to vary from person to person. So if I get infected, I may develop immunity, and somebody close to me gets infected, they may not. It depends on a lot of factors, including how severe was the infection, your age, your immune system, and then the length. In the same way, the length of immunity varies from person to person. So someone may be immune, get infected, be immune to a particular virus for a few weeks, someone else a few months or a year. There's variability. It's not a set point. Why this matters? So if this particular strain of coronavirus gives immunity for, it's not an exact cut point, but like at least a year, this has major implications for the likelihood of a successful vaccination. It has major implications for our ability to get to herd immunity through a combination of naturally occurring immunity, acquired immunity, and through immunity acquired through vaccination. If immunity that you get typically from this particular coronavirus strain doesn't last very long, if it's a matter of months, that could irrevocably change society in big ways, because it means that we would either have to come up with a vaccine that people are getting multiple times throughout the year, and what does that do? So this is, and if coronavirus stays around in the way that it's been around, this could be a big thing. So this is a reason why I'm really paying attention to any information that comes across my desk related to immunity. So what do we know so far? Not a lot. What we can do is we can compare it to similar coronaviruses, and this is what you're seeing in the media and from scientists in this domain. And coronavirus seems to be more similar to SARS, the coronaviruses that cause SARS and MERS, more similar to those coronaviruses than the coronaviruses that cause the common cold. That's a good thing if that's the case. if that means that immunity from this particular strain of coronavirus is more like SARS and MERS, but the thing to be aware of is that SARS and MERS give you pretty serious infections. So coronavirus on average gives you less serious infections, but way more people get it. And so I don't know what's going to happen. We may end up with somewhere in the middle. We may be really close to that 12-month cut point where this particular coronavirus. There have been some studies and reports of people getting reinfected. That's just really early information and isn't interpretable yet. So I'm not, that this is information that we will build over time. So the second thing that I'm paying a lot of attention to is the availability and accuracy of tests. This is specific to the antibodies, but these are a couple of headlines. Should I get a coronavirus antibody tests? Experts explain what we know so far. Coronavirus antibody tests have a really terrible accuracy, researchers say. So thinking about accuracy of tests. This is an example of that study that came out, COVID-19 antibody seroprevalence in Santa Clara County, California. It got a ton of press. Experts in the public health field were really leery of this study because it had some methodological limitations, as well as some of the authors in the study had serious conflicts of interest in terms of owning wealth management companies that focus on biotech. So I'm going to talk a little bit about general principles for information consumption in a bit, but this definitely fits in. So in terms of the different types of tests, we have molecular tests, antigen tests, and antibody tests. There's the three kind of classes right now. Molecular tests are what we've generally been using to say whether or not somebody has an active infection. It's something that you take the swab gets sent off to the lab, they use PCR, and then determine whether or not there's evidence of the virus itself. Antigen tests are something that are more new on the scene for this particular virus, for coronavirus. I think there's one approved at this point. It's the same purpose, so you're testing for active infection, except you can do this one in a clinic. You don't need to send it off to the lab. Active and past infection and possible immunity is tested with the antibody tests. So antibodies will start to show up later on in infection, so you can catch active infections. It's generally not the purpose though, because molecular tests and antigen tests are going to be much better for that. Antibody tests are better used for estimating whether or not somebody's been infected in the past and whether or not they have possible immunity. So three types of tests. And I'll get into where we are with these three types of tests in a second. So the technical lingo here is sensitivity, specificity, positive predictive value, and negative predictive value. These are tough to learn concepts. So I've taught epidemiology in multiple contexts. I've taught epidemiology to undergraduates and medical students. I've been in graduate level epidemiology classes with other epidemiologists in training. And this concept is tricky. It's really tricky. I don't have the time to effectively teach it right now. But what we're thinking about here is false positives and false negatives. That's what we're concerned about. Why am I paying attention? For a number of reasons. If we are able to develop highly accurate and more widespread tests, one thing we know is that this relates to our capacity to accurately test and trace, which we call a containment strategy. So once we get in people who are infected, we can contain the amount of other people that get infected by effectively testing and tracing. Better estimates of how many people have been infected. So when we talk about prevalence, when we talk about case fatality, you can start to get better estimates that are more informative for my own risk, for my family's risk, and for what we should do if we have more accurate tests. We're better able to monitor for herd immunity. We're better able to study immunity, and we're better able to study vaccine and treatment effectiveness, especially vaccine effectiveness, if we have really accurate antibody tests and we know more about immunity. So that's why I'm paying attention to accuracy and availability of tests. What we know about availability, there are people who had questions specifically about availability. What do we know? We know we're not there yet in Ohio, and it varies from location to location a lot. So what is true for Butler County, for example, where Miami is, might be different than what's true for Hamilton County, where I'm sitting right now in Cincinnati. So just as an example, I was on a call very recently with a public health official who I'm not going to name, but that public health official very clearly said that in their location, they're not there yet. And then the question came up, will we be there in the fall? And the answer was, we think so, but we don't know. So we're not there yet, and we don't know when we're going to be there yet. And then there's a lot of questions about why in terms of supply chain and types of tests. That's an interesting topic to get into in itself. But the end point here is, are we there yet? And the answer is pretty clearly no. In terms of accuracy, molecular tests. So do I have the infection? I have symptoms. I go to the doctor. Do I have symptoms? Or do I have the infection? Or I'm living with somebody who has the infection. Do I have the infection? These are the ones that take time. And that should not say in person. That should say in the lab. What we know is that there are low false positives. So if you get a positive molecular test, if you go to the doctor, they send your test off to a lab, it comes back and you get a positive, it's really likely that you have the infection. False negatives, this has to do with what we call sensitivity. False negatives are largely variable. So if you get a negative test result, it could be because the particular swab didn't have enough of the virus on it, even though you are infected. It could be because things have degraded. The contents that it was shipped in have degraded. It took too long to get to the facility. It could have to do with handling at the facility. So if you get a negative result, there's a lot more reasons you could get a false negative than there are reasons you could get a false positive. Antigen tests are the same, except there's even more concern about false negatives. These are the ones that you get at the doctor's office. So for example, if you've gone and gotten tested for the flu, they'll say things like, oh, well, you know, we're going to send it off to the lab to get a more accurate result. But right now, you might not have been sick long enough. You might not have built up enough to show a positive infection. Antibody tests, we're really concerned about false positives and false negatives. False positives in the context of people having antibodies that relate to other coronaviruses, and false negatives in the sense of people who have been infected but have not developed the antibodies. So there's a lot of concern about accuracy. Different tests for different antibodies. That's what different tests. So that's one factor that goes into why certain antibody tests are more or less accurate than others. But that's in terms of accuracy. So the last thing here, vaccine and treatment, and I'm going to start going a little bit quickly so that we have time for questions. So why does it take time? Because we have to go through stages where we're testing safety, then safety and efficacy in really small groups, and then safety and efficacy in tightly controlled group. And every step of the way, we need time to collect people, to see whether or not antibodies are showing up, to get approval, ethics approval for the study. We're doing, the community is doing everything as fast as they can, but to work through these stages to make sure that we have something that is both safe and effective when it comes out just takes a lot of time. Obviously, if we develop vaccine and treatment that has major implications for herd immunity, for risk of getting serious illness and dying, and a vaccine, because we don't know a lot about immunity yet, we know it's possible, but not currently relevant. We saw in the news that one trial found evidence of antibodies from a vaccine. That's encouraging, but we don't know what those antibodies mean yet or how long they might last. So it's encouraging, It's possible, but it's not a guarantee yet at this point. And we've been seeing a lot about hydroxychloroquine. There's anecdotal evidence, but no sound evidence. And the FDA has not approved of, but has issued emergency use or authorization for remdesivir with some evidence of shortened time and severity, but no major large-scale clinical trials yet. So that's a summary of what I'm paying attention to. I'm also keeping an eye on seasonality, what's going to happen in the next few weeks as we open up. Like I said, advancement in our understanding of more short-term and long-term, what we call morbidity. So illness, but not dying, and other systems that are affected. And then what's going on with children. I'm a parent of a 4-month-old and a 4-year-old. And children seem to be at lower risk. We have had relatively few deaths among children in the US compared to other age groups, but something to keep in mind is that children are among the most protected right now. People are usually less risky with their children than they are with themselves. So it's unclear. The risks there seem to be lower, but are a little bit unclear at this point. So I haven't talked about wearing, I talked about wearing masks and respirators. I did actually talk about that. Social physical distancing, washing hands, disinfecting services. Those 3 middle ones, especially because we already really understand that these are means of protection. And I did talk about risk in wearing respirators, masks in the context of other people's questions. So really quickly, and then we'll get into a couple live questions. 3 principles of information consumption. Be skeptical of experts, be wary of agendas, and be wary of certainty. So people are not staying in their lanes right now. You have medical doctors who are talking about public health despite getting very little training in public health. You have, you have microbiologists talking about epidemiology. You have epidemiologists talking about treatment. You have economic experts talking about public health. People aren't really staying in their lanes, and I've seen all sorts of mistakes from my side of things in terms of epidemiology coming from people who aren't really staying in their lanes as experts. So just be wary of people who are claiming expertise in an area and then talking about something that isn't actually in that area. Obviously being wary of agendas, that's a major red flag. People trying to convince you of something. And then being wary of certainty. Some of the worst information I've seen coming out of people right now is the more certain somebody says, like, this is exactly what we should be doing, the worse that information probably is, because from a public health perspective, certainty is not something that we have right now. Okay, so that's really it, because I want to save some time for questions. So now we can open things up to some live questions if you have them.
Thank you, Dr. Smith. We did get a couple questions, actually a few questions that came in as you were speaking. So I will just go ahead and cover those real quickly. The first question is from Cassie, which I think is a question that relates to risk tolerance. She asks, what is the risk level of attending a summer camp where there will be between 50 and 80 people from all over the United States in early July? Attendees will be sharing tents and community bathrooms, attending sessions together, as well as cooking and eating together.
So this gets into, and let me first say that I completely appreciate the question, because we have to make decisions about what to do and what not to do. The tough reality is that there isn't an answer to that question. We don't know how risky that is. The more people, and there's so many variables that come into play, like the weather in that particular place, whether or not there are people coming there who are seriously or going to develop serious infection, how many people are in those enclosed spaces and for how long, the underlying risk factors of the people who are in attendance there. What I would say is I would not feel comfortable sending a child to a summer camp, but that's me based on my risk tolerance level because of everything that I kind of explained and everything that we don't know, especially right now as we're just starting to open things up. That's my perspective.
Okay, thank you. And the next question is from Bob, which I believe is a question sort of related to the tracking data. If in Ohio we're supposed to stay at home when possible, and we're supposed to take safety measures such as social distancing and wearing a mask, can you speculate where the new cases are coming from? Could it be from non-compliance?
Absolutely, it's coming from non-compliance. No question about that as people are getting out and about more. Now that non-compliance is less of a thing now because we just recently, at least in Ohio, the recommendations are now just recommendations. Nothing's changed about safety. And for example, the Ohio governor said that nothing's changed about safety, but they're opening up because of the quote unquote need to learn to live with the virus. That's the rationale. So not confusing what's going on with a change in level of safety. So in terms of the question, yes, people who aren't complying, people who have to go to work, right? Obviously, nothing's really changed about that. People who aren't complying, people who have to go to work, and then people who are in those situations and then interacting with people who are staying home and doing those kinds of things. Molly, you might be on mute.
It was, my apologies. Okay, this next question is from Frank. What are the prospects and an estimate for the timing of development and distribution of a vaccine to protect us from coronavirus?
Yeah, so Frank, that's a great question. And it's another unknown. And I think that's such a theme is like understanding the uncertainty and why there's uncertainty. So let's say best case scenario, exposure to this virus or dead parts of this virus, right? In the case of vaccine, parts of the virus confers long-term immunity. That's best case scenario. We don't know if that's true, but if that is true, a vaccine, the reason that you hear the estimates of a year, 18 months, is because every single one of those stages of those trials, in order to ensure that that vaccine is safe and efficacious, it takes time. And not only that, you usually need multiple studies on one particular vaccine to make sure that the one study that showed something wasn't an error. So when you're seeing the estimates of 12 to 18 months, things coming out like that, it's because we have to go through these very careful steps of first testing safety in a small number of people. And that takes time. And then testing safety and efficacy in a larger number of people. And that takes time. And then what if you get to that phase and the answer is yes, things are looking okay. And then you do a larger trial and the larger trial doesn't show it helps. So you might be in a circumstance where you have to start over and then, have multiple people working on it. But that's where those estimates come from. It's not because people are being lazy or lagging. It's because it really does take that much time.
Great. I think we can squeeze in just maybe one or two more. Marianne asks what your thoughts on wearing disposable gloves, say to the store, out in the world, and then subsequently throwing them away.
So wearing disposable gloves is not something that I've thought too much about, so I'm kind of winging it here. But the concern about disposable gloves is the same thing with your hands in that there'll be a vehicle. So if you're at the store and you get stuff on them and then you touch your face, it's the same thing as your hands normally. The difference, I guess, is the ability to throw them out, right? There's not reason to suspect that process would be that much more effective than just really washing your hands well and washing off the things that you've touched, which you would have to do anyways. So in terms of getting rid of the virus, washing your hands is probably just as effective as throwing away gloves. And in the process of throwing away gloves, you could, I don't know, get stuff up in the air like that. I don't see a huge benefit to doing it. And that would be kind of my off the shooting from the hip response.
Thank you. That was informative. And then maybe one last question here. This is from Nancy. And she asks, when would you perhaps feel comfortable traveling overseas, and what would need to happen first before feeling comfortable to do so?
I don't know that there's a reason I would feel less comfortable traveling overseas right now than I would being in the United States. There are certain parts of the world where things are active, but things are active in my own community. And so there would be so much that would go into play into that equation in terms of where I'm traveling, right? Being on a plane is something that would scare me a little bit. Being in a tightly enclosed space with a lot of other people is something that would make me nervous for sure. That's something I haven't even really thought about that much yet. A, because I don't do a lot of international travel, but B, because that seems really far, for me personally, that would seem pretty far down the road to a point where I would feel comfortable doing that. That's probably for me in the territory of something magical happens and this thing goes away, or we have a vaccine that's being widely used globally. Or just, if you have risk, or if you have like low risk, high risk tolerance, right? So it's a personal decision, but that's me at my risk tolerance level.
That was a good question and actually a very valuable answer. Thank you so much for that. Just as a reminder, before we wrap up today, a recording of this presentation will be available on the website later this afternoon. And we wish to thank you again, Dr. Smith, for leading this webinar today. For all of you viewers, please be sure to follow us on social media at Miami Alum for news on other upcoming virtual programming, and do check out our list of other upcoming webinars. Thanks again to you, Dr. Smith, and thank you, and as always, love and honor.
It's my pleasure. Yes, love and honor, and thank you everybody for attending and asking some great questions that really helped inform my presentation.